please visit www.ccfa.org/resources/webcast. I hope that all of our webcast participants can see the title slide and hear me okay. If you cannot hear me through your computer speakers or headset, please dial toll-free 1-877-309-2071, access code 448-302-909. After the presentation, we will answer some questions from our webcast audience. Webcast participants can ask questions at any time during the presentation by entering the question in your control panel, which should appear on the top right of your screen. If we are not able to answer your question, our IBD Help Center can be reached Monday through Friday, 9 a.m. to 5 p.m. Eastern Time by calling 888-694-8872 or by emailing info@ccfa.org. I now have the pleasure of introducing our speaker for today's program. Dr. Maria Teresa Abreu completed her medical degree at the University of Miami Miller School of Medicine. Her postdoctoral training included an internship and residency in medicine at the Brigham and Women's Hospital in Boston, Massachusetts, a research and clinical fellowship in gastroenterology, plus training in molecular and cancer biology at the University of California, Los Angeles. Dr. Abreu has authored more than 100 peer-reviewed articles, books, chapters, and reviews. Her research interest is host bacterial interactions and the role of toll-like receptor signaling in intestinal inflammation and colon cancer. Her translational work has focused on genotype-phenotype relationships in inflammatory bowel disease and prediction of response to medical therapies. We are very excited to have such a wonderful speaker here today. Without further ado, I will now turn the program over to Dr. Maria Abreu.
Hi, everybody. I'm so delighted that the Crohn's and Colitis Foundation asked me to do this. It really is for me a joy to have the opportunity to provide information to the most important people, which are people that are affected by IBD either directly or because they have family with it. During the course of the day today, on Wednesdays is my busiest day for seeing patients, and I saw 20 patients today. And although for me that's a lot of patients because people that I see are complicated, now in the next hour I have the opportunity to impart knowledge to a much greater group of people than I can ever do one-on-one. I also feel that because of all the things that the CCFA does for patients and for the field of IBD, that there really is almost nothing that I wouldn't do for them. So tonight is an interesting night. We're going to talk mostly about knowledge that was imparted as part of this Advances in IBD conference. We're going to discuss some of the things that were learned by the physicians and the physician extenders that attended that conference, and review some of the active scientific issues related to IBD and also some of the new therapies that are in the pipeline, which all of us are really very excited about. So I want to tell you a little bit about this Advances in IBD conference. Really, I have seen this evolve very nicely over the course of time. I can remember that the very first of these Advances in IBD meeting was held in New York. Now, in the last several years, this conference has been taking place in Florida. You can go to the next slide. And it turns out that this event, this Advances in IBD conference, has become really the single most important event for IBD nationally as well as internationally. 1,900 people are attending the conference. Most are physicians, but I think they very importantly have a big piece of what they do for nurses, dietitians, physician extenders. For those of you that are affected by IBD, you know that you're often, the number of blood tests and things that we do on a regular basis requires a team approach, and part of that team are nurses and dietitians, so there's really something there for everyone. In addition, it's also become a very important place for investigators in the field of IBD, doing very original research in IBD, and I have seen that blossom as well. So I think it's a wonderful thing. In fact, actually, they're victims of their success, because in this coming conference in December of 2014, it's going to leave Hollywood, Florida, which turns out to be in my backyard, and go to Orlando, which I can't stand. But nevertheless, that's going to happen regardless of what I want. So I'm going to tell you a little bit about the clinical issues that came up during that conference. And the first, one of the presentations given at this conference was given by a colleague of mine, Sunanda Kane, who is at the Mayo Clinic, and she talked about mimics of IBD, and you know, for all intents and purposes, as I speak to you tonight, it's very likely that you have been diagnosed correctly. Some of these talks are, again, directed at physicians, and we want to make sure that when we have these conferences, we provide doctors with other things in what we call the differential diagnosis of intestinal inflammation. And so there are obviously infections that can mimic Crohn's disease, such as tuberculosis, such as Yersinia. Yersinia tends to be an infection that is transient and doesn't last as long as IBD. Tuberculosis, for the most part in the United States, we have a low rate of exposure to tuberculosis, but as the developing world is developing more IBD, doctors in these other countries need to be on the lookout for that. When we initially diagnose the disease, obviously we're assessing for all of these different things, such as whether or not this is actually a tumor that's pretending to be Crohn's disease. Some people, including myself, take non-steroidal anti-inflammatory drugs such as, you know, Advil, Aleve, Nuprin, those kind of medications. We can take them for headaches and back pain and all sorts of things like that. And these can cause ulcerations in the intestinal tract. There are also new kinds of medications that are used for lowering blood pressure, and some of these medications can also mimic inflammatory bowel disease. Celiac disease is a disease in which one becomes intolerant to gluten, but not just intolerant to gluten because that's a fad that nowadays everyone is sort of intolerant to gluten, but a disease in which the immune system attacks the lining of the intestine anywhere that the protein, the breakdown products of gluten, which is contained in wheat products, gets into the tissue. And so these are the people that really, really cannot eat gluten. Okay, and so there are miscellaneous other things that can mimic Crohn's disease. This last one about endometriosis is more about, obviously only happens in women, but this can cause abdominal pain and, of course, be confused for Crohn's disease. All right. So now the other things, now moving on to things that might mimic or you know, Crohn's or ulcerative colitis, it turns out that some of the preparations, rarely, actually we don't use it anymore, that the kind of preparation that causes this confusion of ulcerations. Whenever we are doing colonoscopies, we also are checking, I certainly do check stool cultures for this very common bug called C. difficile, Clostridium difficile. Many of you have heard of this. It's now a very common infection, typically happening after someone has been exposed to antibiotics, but not necessarily. You know, there are other conditions such as solitary rectal ulcer syndrome. So uncommon, I'm concerned to have you leave thinking that any of you might have this. Actually, that solitary rectal ulcer syndrome tends to happen in people who have very severe constipation. Okay, so these are some of the things that you know, as Aisha said, you're going to nicely have the ability to download this list of different conditions. But again, I'm confident that if you called into webinar that for the most part, we're dealing with Crohn's disease or ulcerative colitis. People who have Crohn's disease may develop fistulas around their anus, which can be very uncomfortable and very, understandably bothersome. I have seen that occasionally someone's been called Crohn's disease when they really have had complications of delivering children, for example, women who've had vaginal deliveries and have had large episiotomies might develop perianal problems that are related to the episiotomy and not to having Crohn's disease. Again, infections can occasionally do it. And again, very rarely could there be tumors that are involved. Some of the things that Susie Kane wanted to impart to the physicians attending the conference was what other things that might tip the doctor off that this is really not inflammatory bowel disease. And you can go to the next slide. For example, when patients don't respond to high doses of prednisone, that might be a sign that we're not really dealing with inflammation. It could also be a sign that the disease is very severe. There are other things that we might consider, but nevertheless, that's one of the things that we would consider. We should always be thinking about infection in particular, because even if you have ulcerative colitis or Crohn's disease, not only are you not off the hook for developing things like C. diff, but in point of fact, it's a very common thing to have those two conditions be overlapping. In other words, Crohn's disease and ulcerative colitis, very frequently a flare may be caused by an infection with C. diff. All right. So then I believe this was Doug Wolf gave a talk on, who is in Atlanta, on endoscopy in inflammatory bowel disease. Again, for those of you who have it or have family members with it, you know that one of the mainstays for diagnosing the disease, but also for following it and assuring ourselves that the therapy we're using is actually working, is to do endoscopy. Endoscopy, I should say, is the general term that we use for any time we look inside the intestine with our tubes that have cameras at the end of it. We can do that from above when we want to look at the stomach and the duodenum, but most commonly we're talking about a colonoscopy. So I wanted to make sure that those terms were clear. We, for all intents and purposes, always do endoscopy when we make an initial diagnosis of Crohn's disease or ulcerative colitis. It allows us to look at the extent of the disease. So, where is it exactly in the intestine and how severe is it? Are these deep ulcerations or are these very shallow, infrequent ulcerations? You'll see the point made repeatedly in the next couple of slides that a biopsy is absolutely required to make a diagnosis. Interestingly, the reason we need a biopsy is not so much because there's something in the biopsy that says, aha, this is Crohn's disease or this is ulcerative colitis, but rather we do the biopsy to make sure it's not something else, that there isn't something in that tissue that is causing the inflammation. Later on, after someone already has a diagnosis of Crohn's disease, we may want to monitor to see if the intestines are still inflamed. We may want to monitor to see that people haven't developed something precancerous. People with Crohn's disease are not at a particularly higher risk of developing cancer from the disease, except the subset of patients who have most of the Crohn's disease in their colon. We use as a break point that if someone has more than a third of their colon involved with Crohn's disease, that it's those patients that we start doing what we call surveillance colonoscopies to see if they have anything precancerous. Okay? And then if someone has a narrowing in their intestine, then we can sometimes dilate that. Actually, I have been doing that much more frequently. That's particularly true in patients with Crohn's disease that's affecting their the end of the small intestine, the beginning of their colon, who've had surgery, and at the surgical connection, there's a narrowing. That can be dilated, distended, so that we can open up that narrowing. And then the other kind of big use of endoscopy in Crohn's disease is in people who've had surgery, for the Crohn's disease. We can then look to see if the Crohn's has returned. Many of you know that Crohn's can't be cured by surgery, but after someone has had surgery, we try to prevent the disease from coming back, and we want to prove to ourselves that the disease hasn't come back, and the best way to do that is by doing a colonoscopy. Dr. Wolf also wanted to let physicians know that we could be misusing endoscopy in Crohn's disease. He advocated, and I completely agree with this, that biopsies should be done every time you do an endoscopy in someone with Crohn's disease. I mean, when I say this, there could always be exceptions, but generally there isn't. Usually, this is something that we routinely do. That you should do biopsies. You should do sufficient biopsies. He says that not always do you need to do a colonoscopy. The only issue is that with Crohn's disease, the disease can be much further north than just the sigmoid colon. So occasionally, I mean, more often than not, unfortunately, a full colonoscopy is needed. Capsule endoscopy is when patients swallow what looks like a large vitamin pill that has a camera at the end that it basically takes pictures every couple of seconds as it goes down the intestine. I'm old enough now that I can remember the days before we had it and the days after we had it, and it was a giant step forward for GI kind when the capsule endoscope became available. It was actually derived from technology developed in Israel for the military, and allows us to see terra incognita that we had never seen before. We all have between 15 and 20 feet of small intestine, and it was impossible to see it from one end to another before we had capsule endoscopy. What the last bullet point? I suppose the last two bullet points. This capsule that I told you was the size of a large vitamin pill. People with Crohn's disease can have narrowings, we call them strictures, in their intestine, and if we're not careful, then these capsules can get stuck in those areas of narrowing. And then finally, his last comment was that sometimes people who have really almost no symptoms undergo this extensive evaluation, and it's unnecessary to do that. So that occasionally does happen, but I think that's the lesser of the evils, I suppose. In ulcerative colitis, we again use colonoscopies to make the diagnosis, to look at the extent of disease, to see if the ulcerative colitis is inflamed, if the colon is inflamed, or if the colon has quieted down with the medications that we've given the person. Patients with ulcerative colitis, after they've had about 10 years of the disease, can have an increased risk of colon cancer. And we don't want to ever diagnose cancer. We'd rather diagnose something that's precancerous. So we do colonoscopies beginning at about that 10-year mark. We don't necessarily do them every year if the person is perfectly well and there's no sign of inflammation in their colon, but we do them approximately every 2 years or so in patients that are completely healed. There are conditions where we do them every year. So again, that's something for you to discuss with your own gastroenterologist as appropriate. Okay. Okay. So there various different techniques that can be used. Dr. Lichtenstein also had some comments to make about the misuse of endoscopy. Again, I think you can see the recurring theme is that biopsies are helpful because actually some studies have shown that it's equally important to show that there's not inflammation on the biopsies, because biopsies with inflammation may predict people that that need to be on stronger medication. Okay. All right. So, all right. I again had mentioned already that certain people with Crohn's disease are going to need surgery for the Crohn's. And the most common place that Crohn's affects is the very last part of the small intestine and kind of the very beginning of their colon. And in the most typical type of Crohn's disease, and again I say the most typical, but no one is ever perfectly typical, they can get a narrowing in the end of the small intestine that causes a blockage or blockage-type symptoms with pain and distension and bloating that requires surgery to remove that piece of affected intestine. Even with our best medications, the only way we can prevent that is if we catch the Crohn's early. But sometimes we don't, or we can't, or the medicines haven't worked, and that piece of intestine needs to be removed. In modern times, this should always be removed laparoscopically, which is the fancy word for saying that instead of having a long incision, that the surgeon can make a very tiny incision and use cameras and things to remove just that segment of intestine. The advantages are huge because these people that have very tiny incisions generally don't develop a hernia because it's too small to develop a hernia of their abdominal wall. They get out of the hospital faster. It's good for everyone when it can be done laparoscopically. And most surgery nowadays is done laparoscopically. There is a physician, Eva Segesi, who is at the University of Pittsburgh, and she has, made a bit of a science of pain, of evaluating pain in someone with inflammatory bowel disease. Obviously, pain is tricky because we can't really measure pain. It's all a subjective sensation. No matter, if we say tell us your pain on a scale of 1 to 10, obviously that's still a subjective sensation. But pain can be caused by a variety of things, right? Narrowings in the intestine, inflammation. Once someone has had surgery for inflammatory bowel disease, whether it's Crohn's or ulcerative colitis, they can develop adhesions, and those adhesions can cause pain. And of course, it's up to us to try to figure out, well, is it the disease, or is it just complications that could happen to anyone after they've had surgery? Some people, I can say to you that as a treating physician, what's fascinating is the spectrum that I can have people that have horribly inflamed intestines and have no pain, and people that really have almost nothing and have a lot of pain, right? And that really teaches us that there are, these pain receptors can function differently in different people. Having said that, I do feel that it's my job to make sure I've gotten rid of the inflammation before I start thinking that somebody has perhaps irritable bowel syndrome or irritable bowel syndrome type pain, because if I haven't done my job to make the Crohn's or the ulcerative colitis better, then I can't make up other conditions. We try very infrequently to use pain medications like narcotics, not only because they're addicting, and Crohn's and ulcerative colitis are a long-term condition. They're not it's not like having surgery and needing to take some pain medications right after surgery. This is going to be something for a lifetime, and we don't want our patients to have all the side effects of being on narcotics. Moreover, research has found that actually people who are on narcotics have a lot more complications of the IBD, and therefore we really want to minimize narcotic use in our patients. We also know that stress makes people's perception of the pain worse. And so I think all of us have had that phenomenon. If we're having a bad day, that same headache feels like a much stronger headache than when we're having a good day. More and more kids under the age of 18 are being diagnosed with inflammatory bowel disease. And so that is another field that's terribly important, and again, that's a highlight of this Advances in IBD conference. Because we're talking about children, and they have a whole lifetime ahead of them, then one can imagine we want to do the very best by our children because we want them to achieve their full growth potential and obviously minimize toxicity from the medications. Most clinical trials, unfortunately, are not done in children. They're done in adults, and the pediatric gastroenterologist has to then extrapolate how to use that in children. Sometimes that can be an issue, especially trying to figure out the right dose of the medication. As a trivial pursuit question, you can see that there's only one FDA-approved biologic drug for children, and that's Remicade, although all of my pediatric gastroenterology colleagues use basically all of the same medications that we use in the adult world. But of course, they all wish, and we all wish, that there was more studies that were being done in children. There's really very nice studies being funded and supported by the Crohn's and Colitis Foundation, made possible by donations from generous patients, that is studying the microbiome, which is the fancy word for the gut bacteria, in children who have IBD. And in that particular study, they're trying to get biopsies from children right at the time of the diagnosis so that they can study what's happening to the tissue before we start giving those people medications. And in children, because it's not harder to do colonoscopy, but we certainly don't want to put children through invasive procedure. There is a larger reliance on stool tests where we can collect stool and try to measure markers of inflammation. And in point of fact, actually, that's also something we're trying to do in the adult world as well. Okay, great. Shared decision making. So Corey Siegel, who is a colleague at Dartmouth and just a terrific guy, has been trying to figure out ways that we physicians that we can convey better to people the risks of medications versus the risks of the disease and not taking medications. And what good does it do us to do all these studies, find great new medications, discover that 1 in a million people have a particular risk of having something happen, but not be able to explain to someone that that's a 1 in a million chance that that's going to happen versus a very high chance, a 1 in 100 chance that something is going to happen. So he figured out the first thing is that you have to try to keep the same denominator when you're trying to convey a concept like 1 in X or 10 in X. Keep the X the same so we can make it easier for people to understand. The other issue that we face is, I'll jump to the last 2 bullet points, which is that if you check with Dr. Google about any of the medications that we're going to talk about towards the end of my conversation with you, you'll be scared to death, right? Because it's all about the risk. You could die, you could you could fall off the building, but none of the benefits, right? There's a rare chance that you go on something and you'll fall off the building. But there's like a 70% chance that you're going to get a whole lot better from starting medication X. And so that's what we talk about risk-benefit, that for the most part, there's almost no medication that I prescribe that doesn't have a whole lot more benefit than risk. Okay? But yet we spend most of the time in our visits with patients discussing risk. The last point there about absolute risk versus relative risk is, I'll give you an example. Maybe I have, we're all going to get skin cancer. Maybe not, but someone's going to get skin cancer. And maybe the chances that someone who's on certain medications for their IBD has a 3 times higher risk of having skin cancer. Well, the relative risk in that case is 3 times. The risk of someone on the medication is 3 times higher than my risk. Okay? But in a way, that doesn't tell you that much. Okay, so my risk is higher, but is that meaningful? Well, it depends. It depends on really this absolute risk. So if the chances that I'm going to get a skin cancer is only, 1%, and I make that risk 3 times higher by taking a medication, that means that my chances of getting skin cancer are now 3%. So 3 in 100 people. Well, 3% means not much. I still have a very low likelihood of developing that skin cancer. I hope you're following what I'm saying because I can't look you in the eye. Yet, if my risk of skin cancer were really like 25%, to pick a number, if now I make that 3 times higher, then I make it like a 75% chance that I'm going to get a skin cancer. That's a lot bigger number, right? A lot bigger chance that me as a human being is going to get that skin cancer. And so you can see why both numbers are important. But at the end of the day, you really want to know what's the absolute risk. And for most of the risks of the medications we use in IBD, and I bet you that'll be a lot of the questions we get later, the risk, the absolute risk that something's going to happen to you as an individual is unbelievably low. And and sometimes it doesn't help to, I think we physicians can confuse people by explaining things with all these numbers and give people make people confused. All right. So now we're going to change gears a bit and talk about something near and dear to my heart, which is some of the scientific aspects of inflammatory bowel disease. And most of you are familiar with the idea that IBD is genetic in origin. It's more common that people who have, it's common that people who have this disease have family members who also have this disease. That happens about 20% of the time. That means that 80% of the time, the person who we see as a patient, that is the first person in the family who has inflammatory bowel disease. Using modern technologies to discover what genes cause inflammatory bowel disease, we've made an enormous amount of progress and have identified 163 different genes that can all play a role in ulcerative colitis and Crohn's disease. And highlighted on this slide is really the most recent enormous study, there are always more recent studies because the field moves quickly, but the most recent ginormous study of something like 70,000 people with either Crohn's or ulcerative colitis in whom their DNA was studied. That study found a couple of really interesting things. The first is that, again, many of you have been confused by us into what is my disease. Is it really Crohn's disease? Is it really ulcerative colitis? Is it Crohn's? Is it ulcerative colitis? And sometimes I saw a patient today who, quotation marks, was diagnosed with ulcerative colitis and then it became Crohn's disease. Okay. One of the things you should take away from this is that the majority of the genes that have been discovered are actually genes that are in common between Crohn's disease and ulcerative colitis, and that there are only certain very specific genes that distinguish those two disorders. The other interesting discovery from these large genetic studies is some of the families of genes that kind of are grouped together. What do I mean by that? I really actually don't know that this is true what I'm about to say, but I'll just make it up. I have brown eyes, and there might be 10 different genes that lead me to have brown eyes. So they're all kind of genes that may have different names, but they're all working together to make brown pigment in my iris. Okay. Likewise, we can look at all these 163 genes, and using computerized approaches, lump these genes into families of genes that are related and that have some common function. And when that approach has been used, some of the pathways that kind of pop up are interesting because they're pathways that are important for fighting off infection and for diseases that go along with having a deficiency of the immune system. And so I find that interesting because, there's always been a debate about whether, Crohn's or ulcerative colitis is an infection. And although I don't think it's going to be something simple, I think that maybe someday we will discover that there are certain particular types of bacteria that may play a role in IBD. This second slide, I think, covers a lot of the same concepts that I've tried to share with you. And so the only last point I want to make on this is that really it's a lot of the support and the pioneering work funded by the Crohn's and Colitis Foundation that has moved that field forward. Well, another very hot topic in IBD is the microbiome. And that's a fancy word that refers to the environment of the intestine and all the things that live there. And trust me, a lot of things live there. So what lives there? Well, if you're asked in a Trivial Pursuit game if we have more human cells in our body or more bacteria, the answer is we have more bacteria, at least 10 times more bacteria than we have human cells. And this is living in our colon every day. And for those of us that don't have IBD, the really interesting thing is how come we don't all have IBD, given how much bacteria are living in our intestine all the time? So obviously, people that have IBD, there's something, it's either on the bacterial side or on the host side. It's either them or it's the things that have set up shop within them that is leading to the IBD. Most work that has been done so far has been done focused on bacteria. However, I think in the coming years we're going to have a much bigger focus on fungus, like mold, but it's not really, they're not growing like in colonies, but fungus that lives inside of our GI tract, and viruses. We're all exposed to viruses, some of which live long-term in a dormant state in our intestine. All right? There's also obviously that same question about whether or not Crohn's is an infection. And so, there are obviously investigators that are still trying to work that out. One of the kind of reasons that the study of the bacteria that live in our gut has really taken off is because we now have the tools to actually understand what is living in our gut. In the past, we depended on petri dishes and trying to culture bacteria, if you ever were in high school science. But now we use what we call sequencing to look for, to look very carefully at what bacteria are living in our intestine by looking at the genetic code of these bacteria living in our intestine. Okay. That bacteria, again, on this slide, the only point I want to make is that the bacteria living in our gut is highly influenced by our diet, highly influenced by our diet. And, many of our patients want to know, well, what should we eat? Well, one of the conundrums is we don't yet know, but need to research, what best to tell you to eat to shape the gut bacteria in such a way that would be beneficial for the treatment of Crohn's and ulcerative colitis. And maybe we'll discuss that during the Q&A. So this is my kind of conception of what's happening in IBD. In the orange puzzle piece, it's to denote the fact that there is probably a core group of genes that people with IBD inherit that make them susceptible to having intestinal inflammation. And then there are other genes that might shift the expression of the disease so that it looks more like what we, quotation marks, call Crohn's disease versus what we call ulcerative colitis. And even if you have this genetic susceptibility, these diseases don't happen unless you have the right, or in this case, the wrong microbiome. And so we're actively pursuing what could that change in the microbiome be that unmasks this genetic predisposition. Okay. So now I think we'll talk for the next couple of slides of some of the exciting advances that are taking place in our world of IBD. I think that in the coming years we're going to start trying to do studies in what we call early Crohn's disease. We recognize that we've been waiting too long to start people on medications for their Crohn's. Now, I will say that sometimes it isn't the doctors who are giving pushback, but also patients who really are reluctant to go on medications. But again, time and time again, what we have discovered is that the longer we wait, we might miss that window of opportunity to treat the inflammation before it becomes, before the complications, the narrowings, and that kind of thing sets in. We are also trying to develop better ways to predict the future, doing special tests to see is this someone who's going to have more aggressive Crohn's disease or not. But even without fancy tests, certainly if people are smokers, if people have very extensive Crohn's disease with deep ulcerations, all those are things that would suggest that it's more aggressive disease. All right, let me tell you what we're most excited about. So far, one of the big advances that has been made in the treatment of both Crohn's disease and ulcerative colitis is the use of anti-TNF medications. Most of you on the call, or many of you on the call, probably know about these medications. We now have 4 medications in that class approved. The first one is infliximab, known commercially as Remicade. The second one was adalimumab, known commercially as Humira. The third one, those two, by the way, are approved for both Crohn's and ulcerative colitis. Certolizumab pegol, which is commercially known as Cimzia, is only used in Crohn's, and golimumab, which is called Simponi commercially, is now approved for ulcerative colitis. Okay, So for each of these diseases, we have 3 anti-TNF medications that work. And in my feeling is, and not forget my feeling, the data are, that this is a huge advance for the treatment of IBD. And I feel that one of the most impactful things I do is starting people on these medications. Okay? However, there are a few things. The first is nothing in life is 100%, and so therefore 100% of people don't respond to that medication. The second is we have a lot of patients that respond to anti-TNF medications but go on to lose that response over time, and we're desperate to find other things that we can use to treat them. And finally, there are people that never get to use these medications because of miscellaneous reasons. They've had multiple sclerosis, they've had a history of cancer themselves, possibly even recently, and we're reluctant to give them a medication like an anti-TNF that could interfere with their ability to fight off a recurrence of the cancer that they already had. Notice that I'm not saying that those medicines cause cancer. I'm saying in a person who already has had cancer, we might not want to do anything to interfere with their immune system. So there's a new medication that we hope is going to be approved in May, which is that tomorrow? Oh my Lord, I think May starts tomorrow. That will be approved in May, and we believe will be available to patients starting in June. The medicine is called vedolizumab. It works by a different mechanism than the anti-TNFs. It's also given as an infusion. We also call it a biologic. It ends in a MAB. Notice how it ends in a monoclonal antibody. That's what MAB stands for. And this medication, what it does is it blocks the ability of certain white blood cells we call lymphocytes, which are really kind of the generals orchestrating the inflammation. It blocks them from being able to get into the intestine in people with IBD. So it's reasonably specific to the intestine. In other words, it only blocks these inflammatory cells that are trying to get to the intestine to make mischief. My, I think, best analogy is that it prevents new recruits from going to the war zone. Okay, so it prevents new recruits. The soldiers that are already in the field have to either die there or leave the intestine in order for the person to get better, and that happens over time. So these medicines work well, but they take what seems like a bit longer than the, infliximabs and adalimumabs that I just described to work, but they work well. There are 2 back-to-back articles about this in the New England Journal of Medicine in October of last year. So that we're excited to have. Ustekinumab is a medication that is used currently. It's FDA approved for psoriatic arthritis, but we know it also is effective in Crohn's patients, in certain Crohn's patients that have failed anti-TNF therapy, and occasionally we ask insurance companies to allow us to give it to a patient with Crohn's disease, even though it is not FDA approved for that. Likewise, tofacitinib is approved for rheumatoid arthritis, and there the results look very promising for treating ulcerative colitis with tofacitinib, but because it's expensive, insurance companies have been reluctant to allow us just to give people with ulcerative colitis the tofacitinib. I already mentioned golimumab when I told you that this is an anti-TNF medicine that's approved for ulcerative colitis. And then the other kind of nice thing to know about is this budesonide in a colon release preparation. It's called Uceris commercially. We use this in people who have ulcerative colitis who are flaring, but where the flare isn't so bad that we can actually get away with using a steroid that acts just by coating the lining of the colon. So it's a nice alternative to having to use things like prednisone, which I'm sure makes some of you shudder at the thought of needing to use prednisone. So in my view of the world, we have patients that have inflammatory bowel disease, and as time goes on, we may be able to predict whether that person is someone who is going to use medicines that block TNF, medicines that will block other chemicals produced by the immune system. This is the mechanism of ustekinumab, or medicines that will block the ability of white blood cells from getting to the intestine. We're going to use small molecules that will target other pathways that are inflammatory. And I think that really we have a very bright future because we have, for the first time, many different medications working in different pathways to treat people with inflammatory bowel disease. So as I said many times today to patients that I had the privilege of seeing, I want everyone to be very optimistic and hopeful about the future. I hope that many of you are doing fantastically, but for those of you that are not, please hang in there, because there are lots of new things that we hope to be treating you with in the near future. So with that, I'll turn it back over to Aisha, who is going to tell you about some of the great resources of the CCFA.
Thank you very much, Dr. Abreu, for your informative presentation. In addition to the various resources you have heard about during today's program, the Crohn's and Colitis Foundation of America is also here to help. Our IBD Help Center is open Monday through Friday, 9 a.m. to 5 p.m. Eastern Standard Time at 888-694-8872, by email at info@ccfa.org, or you can chat online with an information specialist directly via Answer Chat. You may visit www.ccfa.org for more information. If you'd like to watch our educational webcast on IBD, please visit the website on the screen to explore other IBD-related topics. You can also connect with other IBD patients through the CCFA community website at www.ccfacommunity.org, or by joining a support group or our Power of Two peer mentor program. Finally, GI Buddy is an online tracking tool and mobile app that has everything you need to stay on top of managing your inflammatory bowel disease. Visit www.ccfa.org for more information. Be sure to join us Thursday, July 17th for a webcast titled What's Best for Me? Treatment Options in IBD with speaker Dr. David Rubin from the University of Chicago. If you're looking for other ways to be involved with CCFA, join a local Take Steps walk in 2014. Find an event near you at the website listed below. You can also support CCFA by participating in Team Challenge. Find out more at the website listed. I encourage all of you to complete the post-program evaluation. Your feedback helps us shape future programs. To complete the evaluation, select the link in the chat box within the toolbar on the upper right portion of your screen as shown. Now it is time for the question and answer part of our program. For everyone's benefit, please keep your questions general and related to today's topic. Webcast participants can ask questions by entering the question in your control panel, which should appear on the top right of your screen. Okay, our first question asks, how long should you stay on Humira before you might get some of the side effects?
Some of the side effects? I'm assuming I'm the one answering these, Aisha, huh?
Yes, Dr. Yes.
Okay, so, time to side effects. Most people don't have side effects. You read a laundry list of things that can happen that mostly don't happen. So that's the good news. Some people with Humira complain to me that it hurts when they inject themselves. And if that's going to be you, it generally starts from the beginning. It's not something that necessarily gets worse over time. Everything can happen, but if you're that person, you're that person. We recommend, and I'm sure your doctor recommends something similar. We recommend that people have their blood work done approximately every 3 months to monitor just for the vagaries of things that can happen. Very rarely do people have any complications, but we like to monitor them. And some people develop rashes. People can become allergic to these medications, and that can happen at any point in time. So there's no one time that people that are on Humira or any of those medications are doomed to develop side effects. Most people don't, but they can happen at any time.
Okay. The next participant would like to know how accurate are Prometheus tests and how much do they influence how doctors prescribe Imuran and Parenthal?
Oh, and Parenthal. So how accurate are they? Well, you got to ask the question of the right person. So the first one way to use a test is to make the diagnosis. Okay, so very occasionally we have people that it's hard to know, really, is this Crohn's and is this inflammatory bowel disease, or is it really, or is it not? And these tests can be helpful in that context. The other way in which they can be helpful is in someone who's just been diagnosed with Crohn's disease. The blood test, depending on the pattern of the test, can help predict if this is someone who's going to have, very aggressive Crohn's disease or not. So your doctor may use it in that way. Now, I don't want that to be, and therefore they might say, oh, well, the test looks like you're going to have more aggressive disease. Let's start you on X. I think that usually, for the most part, we base the medicines we're using on what we're dealing with at that moment in time. And what do I mean by that? If we find inflammation, we want to treat it. We're not sort of necessarily treating for the theoretical thing that might happen in the future, but for the now. However, in people that have these markers where, the Prometheus panel suggests that they're going to have aggressive disease, if they are doing fine and there's no bad inflammation at that moment in time, we might say to that person, look, these markers look bad, but let's follow you more carefully. Let's just see you more often. Let's do whatever we want to do more often. The choice of 6-MP and azathioprine, what I think I just want to, I don't know, this is what the question was directed at, is that Prometheus also just does some of the special blood tests that we do before we start a patient on 6-MP and azathioprine. That special blood test is just something we do routinely in anyone we begin these medications on, but it doesn't help us necessarily in diagnosis. So hopefully I addressed that.
Okay, great. And we have time for one last question. If anyone's question has not been answered, please be sure to contact the IBD Help Center, and we'll give you that phone number again at the end of this webcast. So there's another question that asks, are there studies being done out there on diet and the microbiome?
I sort of feel like write to your congressman. There are some studies being done. I don't think there are enough studies being done. And I'm a little bit biased because we've written, a proposal to study this, to study diet, to give patients with ulcerative colitis 2 different types of diet and see how they feel, and study their microbiome before and after. But all studies that have to do with diet, and in this diet study, we plan to give people give them the food. Give them 3 meals a day and 2 snacks, okay? Because we reason that otherwise, if we just say to people, eat this and that there's going to be too much noise. People are just going to, they're not going to know exactly what to eat. And all studies of diet can be imprecise. So they're not, for scientists, as perfect as we want to make them. But they need to be done. And there are some initial efforts to try to do them. And not just changing the microbiome, but really, sure, we want to study whether it changes the microbiome, but we want to see if it makes people feel better, even if it doesn't have a dramatic effect. Maybe it's not going to be Remicade, but I do think that diet plays a role. I think that there are probably certain things that we can advise people with Crohn's that they should avoid, people with ulcerative colitis that they should avoid, that gives people useful information, because I think it's too hard to say to someone either. I think the patients I see have either been told diet has nothing to do with it, or the poor things are on such a restricted diet that life isn't worth living anyway. So it's got to be somewhere in between. And let's hope that we will continue to to investigate this and so that I can answer that question with real facts in the future.
Great. Thank you to Dr. Maria Abreu for her insightful presentation and answers to our questions. If your questions were not answered, you can call CCFA's IBD Health Center Monday through Friday, 9 a.m. to 5 p.m. Eastern Time at 888-694-8872 or by emailing info@ccfa.org. An archive of today's program will be posted on CCFA's website within the next 48 hours at www.ccfa.org/resources/webcast. On behalf of the Crohn's and Colitis Foundation of America, thank you for joining us. Goodbye.